Hello, everyone. My name is Susan Paddock, and I'm Chief Statistician and Executive Vice President here at NORC at the University of Chicago. NORC conducts research you can trust. Today, we're going to share 3 such pieces of research, and we're also going to tell 3 stories. The first is, frankly, a very concerning story about how students from lower income families are struggling to keep up with their schoolwork amid the pandemic. Jennifer Hamilton, Vice President of Education and Child Development at NORC, will present that research. The next story is one that surprised me. It's about how NORC set up a successful contact tracing program in Delaware in a matter of weeks. David Cotton, Vice President of Public Health Research and Evaluation, will share that story, as well as data from the contact tracing programs themselves. And finally, Mike Dennis, a Senior Vice President who leads AmeriSpeak, our nationally representative research panel, will tell the story of how Americans over 50 responded to the pandemic. We'll take questions after all 3 presentations, so please submit them as we go along by clicking the Q&A button. And just a quick reminder that this webinar is being recorded. And now I'll hand things over to Jennifer Hamilton.
Hi. So as Susan mentioned, so much of research really is storytelling. As researchers, we collect and use data to tell stories that we hope are going to make a difference. And today I have a story that is troubling, but probably not particularly surprising. It's a story of low-income high school students and how they were disproportionately affected by the pandemic. So, hello, my name is Jennifer Hamilton. And before we really dig in, I wanted to share the next slide with you. So next slide, please. So if you know me, you know that I love to talk about this stuff. So after the end of this webinar, I'm going to try to keep it going over on Twitter. So if you'd like to join me, we can continue a conversation there. You can find me by searching for my handle, which is @LimeyGirl, or using the hashtag NORC chat, which is here on the screen. Okay, to begin. Next slide. My team and I applied for an NSF grant back in the day because of this statement here on the screen. And as a first-generation college student myself, this is a topic that's very near and dear to my heart. The next slide shows the two main goals of the study and kind of summarizes our methodology, right? So the first goal is to really understand what was happening in the spring of 2020. And then the second goal is to measure it. And this presentation here focuses on the goal 1, the understanding. Goal 2, we're still working on, we're still analyzing the data, so we'll be reporting on that at a later date. But to understand what was happening in the spring of 2020, we used the AmeriSpeak standing team panel, and I think Michael Dennis is going to talk about that AmeriSpeak a little bit later. But we use the team panel, which is a nationally representative sample of students aged 13 to 17, and we surveyed them about their STEM learning during the pandemic. So to summarize the results of that AmeriSpeak team panel, if we go to the next slide and the next one, we started off asking about what was happening prior to COVID. So we found that 46% of high school juniors and seniors across the country had considered a STEM career, which is amazing. But when we broke that down by low income versus higher income, we can see that it's very different. So students in higher income families, it's 73%, in lower income families, it's 34%. And that is a statistically significant difference. So if we move to the next slide, we can see that these disparities prior to COVID are already concerning. So looking at, grades, the lower income students reported lower instances of getting mostly A's and B's, and also their enrollment in STEM classes. was lower than the higher income peers as well. Next slide. So next we turn our attention to what was happening during COVID. So this is again in the spring of 2020. And the next slide will show us that students were experiencing a wide range of challenges as they were accessing their online learning. So as might be expected, there are some students that didn't have internet at home, or if they had it, it was very spotty. If they had a device to access it, sometimes they had to share with their siblings and their parents who were also maybe working from home. They didn't have a webcam, they didn't have a calculator, and those kinds of things made it very difficult. And the next slide shows some more challenges in terms of, if you can just go back one more. Thanks. So this is kind of other obstacles that they were facing in terms of like the home was noisy and crowded and it was hard to pay attention. The teachers were using different kinds of applications and they had to bounce between different applications, which was challenging. So there's a wide range of challenges for students. And we asked them actually to kind of grade their teachers and their schools, and that's shown on the next slide. And they gave overall their teachers and grades a grade of C for being able to accommodate their needs and being effective at remote instruction. And to be clear, teachers and schools were asked to do a lot, like a lot. In the spring of 2020, they had to shift everything to remote instruction on a dime, and it was very, very challenging. And I think over the course of the spring semester, teachers and schools got much better at this. So the next slide is kind of where we start getting into kind of the nitty-gritty here. So we asked them if they were worried about their STEM education moving forward. And we can see that 35% of students overall were worried about their STEM education. And again, when we break this down by income, we can see that it's 83% of lower income students were worried compared to 67% of higher income students. And this kind of translates also into this next slide, where we looked at the students who were enrolled in AP STEM classes. So this is calculus, biology, chemistry, physics. These are the ones there are many more, obviously, but these are the ones that were kind of ready to be showcased. So here we can see, for example, in physics, of the students who took AP physics, 51% of them did not take the exam. So these are the students who were already like achieving and interested and motivated in STEM classes, enrolling in AP classes, and then not taking the exam. And if we go to the next slide, we break this out again by income, and you can see that it's really the lower income students who didn't take the exam. And this is the part that's very concerning. So for the STEM pipeline into college, it's being narrowed here at this point of the students who are interested in STEM, who are taking the classes. But at this point, because of COVID, we assume that it's because of COVID, they're not taking the exam. So it's very concerning. And I want to point out that the College Board actually did a whole lot to encourage students to take the exam. They shortened the exam, they put videos up on YouTube, they were handing out devices, they got grants to do that. So a lot of effort went into making sure that students were able to take the exam, but they ended up, not doing it at these rates here. So just to pause and take a breath, because I get a little bit riled up here. The next slide goes into goal 2, and we haven't finished goal 2 yet, but we know from the existing literature on the next slide here that, people, other researchers out there are estimating a learning loss of 50 to 63% in math. But a lot of these estimates are based on assumptions and some slide research, and often don't include high school. So our measurement part of the study that we're working on right now, using infinite campus data of, I think, 2.5 million high school students, is really going to be able to allow us to measure everything a lot more precisely, and precisely for different kinds of students living in different areas and that kind of thing. So the big question is, where do we go from here? And those are the next few slides. So where do we go from here? I mean, and this is up for debate. This is not me kind of giving out all of the answers or anything. So, as education professionals, I'd sure love to hear what other people have to say. But on the next slide, I have a few ideas. We need to prioritize access to online education. I think remote education is not going to go away. And so we need to work on that. Even though I say assess students early to differentiate instruction, I don't necessarily mean like standardized tests. I think teachers know very well what students' needs are. And so assessing them so we can figure out who is where. Coordination, more time for teachers to plan with the other teachers, looping, and high-dose tutoring. So research-based programs that we know are effective, like high-dose tutoring, can be implemented, including things like extended learning time and summer academies. So that is the end of my presentation. I hope I didn't go over too much time. I'm now going to turn it over to my colleague, David Cotton, Vice President of Public Health Research and Evaluation, to talk about the COVID contact tracing. Thank you.
Thank you, John. Those are very concerning findings, but it really is great to have a quantification of the problem so that we all know what we need to fix. Good afternoon, everyone. It's great to be with you today to talk about the work that we're doing in contact tracing. I'll be focusing on the work that we're doing with 2 state health departments in Maryland and Delaware, and talk a bit about how we're helping the city of Chicago with its contact tracing efforts. As you're hearing from Jen and Michael's presentations, NORC's 80-year history is rooted in survey research and other types of research and evaluation. In March and April of 2020, we were all reeling from the prospects of for our country's well-being, and didn't know how the pandemic would affect our clients and our research work. But we were ready to do whatever we could to bring our skill set to bear on helping this growing COVID-19 that was just overtaking the country. Then in April of that year, we were approached about bidding on a telephone-based contact tracing work for the Maryland Department of Health. We had never undertaken a public health service like this, and really no one had ever done contact tracing on this scale. But we realized that our survey research experience and the handling of sensitive health information put us in a very strong place to help with the contact tracing work. So as you see from the timeline, within 8 weeks, teams across NORC came together to seamlessly launch not 1, but 2 instances of this brand new service offering. Our teams were successful not only in getting operations up and functioning in record time, but also in getting people to actually answer their phones and complete the contact tracing interviews. And a rapid response clearly was required for this unprecedented situation to meet this public need. And as you'll see from the timeline when you can get the slides, from the point we heard about the potential need to the time we started working was less than 2 weeks in each of Maryland and Delaware. And within 8 weeks, we were fully functioning and dialing for the contact tracing work. That 8 weeks included working with states and an external IT vendor to set up the data management systems and the call scripts, and then developing a fully remote training program and hiring and training almost 600 contact tracers within the 2 states. This kind of responsiveness, I think, was only possible because of that extensive experience we brought setting up large-scale data collection operations and handling that sensitive health data for federal and state clients. So let me just give you a brief overview of what contact tracing entails so that you can have a better sense of how we're applying these adapted data collection skills. Once someone tests positive, their laboratory confirmed data get forwarded to the Health Information Exchange that's a part of required laboratory reporting. People who are positive for COVID get called and informed about how to protect themselves and those around them, given guidance for isolation during their infectious period, and asked for the names of people with whom they've had close contact and may have exposed to COVID. We then call the contacts to let them know that they may have been exposed and that they're expected to quarantine to protect their community from further spread. In both cases, people are contacted as in follow-up for up to 14 days by SMS, email, or phone to check on their symptoms and see if they need any resources to help them through their isolation or quarantine. In fact, in Chicago, we're establishing a resource coordination hub to support people who are affected by COVID, something akin to a 211 system, a one-stop shop to help link people with needs to a variety of community-based services. So what is it actually that we're doing? The success of this and operational success depended on a successful collaboration among multiple research departments, our survey field operations team, our IT team, and our telephone survey operations team. We're working on a platform that uses Salesforce as the case management system, and it's integrated with Amazon Web Services telephony. Our IT project managers have done an amazing job bridging another vendor's product that was being operationalized and implemented by the NORC deployment team. And one of the things we've realized is that this role has been critical in helping the health departments maintain a robust system that works in practice and for a variety of users, not just the NORC contact tracers, but folks in local health departments, as well as state epidemiologists who are all working on this related efforts. Most of our workforce has been fully remote using their own computers for connection to the system. And we have been doing recruitment, training, and development and quality control all done remotely. We've had great success with the remote training, and it's already being incorporated into other survey projects we're doing. We're running 7 shifts a day, 7 days per week, including all the mini holidays over the last 16 months or so. We've done a lot of tweaking of the schedules over the past year to better respond to when people are most likely to pick up the phone. Because our contact tracers are primarily from the states that they're working for, they know the local area, the community context, and a big part of our success is due to their commitment and their embeddedness within their communities. So if we can go to the next slide with some metrics, I'd like to just talk about how large this operation has been. These give you a sense of the scale and of the first 15 months or so, and the operation is ongoing and probably will be, I'm guessing, through spring of next year. We've been in a near constant recruiting, training, deployment cycle throughout the pandemic, and we've had a great response from Marylanders and Delawareans who want to participate and help out within their state. We've also had great response from our recruiting and training teams who have been in this constant cycle of revising trainings because of systems changes, bringing on new cohorts. They've been dealing with the staffing implications of the multiple surges and declines we've seen throughout the pandemic, all of which are exacerbated by the burnout that callers can experience in working with COVID. Given the high volume of cases we've had at various times, we introduced inbound calling to optimize the likelihood that a respondent would find time that met their needs so that we could get a completed interview and begin the process of working with them. We also initiated introductory text messages to both legitimize the phone number that people see, so they will pick up their phones, It also increases the likelihood that they will call into the inbound line and increase the number of responses that we get. So finally, what have we learned from this pivot? There are a few things I think that made it successful, and we're taking the lessons from contact tracing back to our research work. First of all, we found that technologies that have been developed for other fields can be applied to both public health surveillance and research. Salesforce has great potential as a case management tool, and we've begun employing it in some of our research projects already. Amazon Web Services, AWS, has performed well as the telephony infrastructure for contact tracers working from their own computers and internet connections, and it can be used as a tool to facilitate distributed contact centers with applications for other data collection projects requiring a soft phone solution. We and our clients have benefited greatly, as I said, from our IT team, who have served as effective consultants and problem solvers for the clients as well as for other vendors. They've really been the glue that has helped hold together the systems and operational sides of the house. We were effectively refining a system that we were implementing and being held responsible for, but not developing, and that's always a tough place to be, and they've really helped out greatly with that. In dealing with this high volume of sensitive data, we brought to bear consultation on telephone data collection best practices and questionnaire scripting. We've helped integrate multiple data collection modes, and we have helped with large-scale call center system design to make the contact tracing process efficient and ensure that the solutions met the needs of all these various stakeholders and end users. In terms of supporting this large data collection cohort, we found that remote and asynchronous training is as effective as in-person training has been for us historically. Our field management team applied their expertise as well in managing these remote workforces and forecasting interviewer and supervisor needs in this ever-changing pandemic. And while we've had interviewers working remotely in the past, what was new here was that they were all working from home, and that introduced new challenges, and we've learned a lot from that experience. The field management team helped us weather these surges with incentive programs to get extra shifts and calling hours, as well as finding ways to keep interviewers engaged during the slower periods. So in closing, I would just say that the hundreds of NORC colleagues that have been working on this project have put in incredible effort and hours to make all this work. I think I speak for all of us in saying that it's very satisfying to have had such an instrumental role in helping address the pandemic. We've seen that we can successfully translate a variety of research-derived skills to a public health service offering, and we're ready to do this again as the need arises. And finally, this effort really encapsulated the collaboration that I think characterizes all of our work. This is an enterprise-wide effort that required all of us to bring our best, and I think it's yielded great outcomes for our clients. So with that, I'm looking forward to any questions you may have later, but I'll turn it over to my colleague, NORC Senior Vice President Mike Dennis, who will speak about the AmeriSpeaks pandemic research. Thank you.
Thank you very much, David. That was a really effective demonstration from my perspective of NORC's capacity to quickly mobilize at scale to address a enormous public need, especially from an information technology perspective. So on that theme, my presentation is largely about how NORC can do the same thing with polling by using, in this case, infrastructure that we've developed for AmeriSpeak and also Foresight 50+, using pre-recruited households, otherwise known as panels. Next slide, please. And of the dozens of studies that we did on AmeriSpeak in the last year and a half related to COVID issues, we selected 2 project case studies today to share with you. I will be giving you also some research findings But being primarily a sampling and methodologist, survey research expert, I think I'll probably emphasize methods a little more than the findings. But please do feel free to look up these studies yourself to burrow into the findings. The first case study involves mental health in COVID times. If you can go back one slide, please. And the mental health and COVID time slide project was selected largely so that we could demonstrate the Foresight 50+ capability, which we rolled out earlier this year to the public. And the second case study on the right involves our sponsors at the Centers for Disease Control and Prevention, specifically the National Center for Health Statistics, using their RANDS program. It's the Research and Development Survey arm that tests various question wording experiments related to the National Health Interview Survey. Okay, next slide, please. And we'll move on to the next slide, which is more substantive. So related to the mental health study for ARP, the first question is why? Why was the research done? And ARP, as you probably know, is a mission-driven, not-for-profit membership organization dedicated to improving the lives and well-being of all Americans, but particularly persons age 50 and older. So we have tremendous mission alignment between our two organizations with respect to NORC's goals as well for informing decisions that ultimately will benefit all Americans and their well-being. So in this case, ARP was quite concerned about the pandemic's impact on the mental health of older Americans. And at the time, we were developing, and if you can move to the next slide, something that we call Foresight 50+. And this has been a couple of years in the making. And essentially, it's ARP and NORC forming a partnership to create first-class, scientifically rigorous survey research infrastructure so that organizations of all types, whether it's consumer-oriented market research or public policy-driven surveys, or surveys like this one, looking at the mental health impacts from COVID-19, regardless of the topic, we saw a need to step in and develop a nationally representative panel of pre-recruited households with people aged 50 and older that could be used for quick response surveys, academic research, et cetera. And that's what we've done. We launched it last June, and it's an ongoing concern now. Moving on to the next slide, what we get to now is about Foresight 50+ in terms of sample representativeness and response rate enhancement. And we did want to make everyone aware that the underlying sample does use extensive refusal conversion as part of the process of building this panel of households. So when I say two-stage recruitment here, I want to be clear that we're talking about the recruitment of the households in terms of enrolling them into the panel. I am not talking about the actual methodology of conducting client-driven surveys. The client-driven surveys are primarily online and telephone mode surveys. But in building the panel itself, we feel very strongly that we need to do that face-to-face, in-person field recruitment to make the refusal conversion really work. And we see that particularly with low-income households, lesser educated households, households comprised mostly of Spanish language dominant individuals. These are all segments of our society that are typically hard to reach for empanelment and surveys, and hence we resort to the extensive face-to-face recruitment to assure that we have adequate sample representation for those segments of our society. Okay, moving on to the next slide. So about the survey itself that we did here, we used the Foresight 50+ Omnibus product. We have monthly a survey that is a multi-client vehicle that focuses on the persons age 50 and older that make up our Foresight 50+ panel. And typically this Omnibus survey might have 4 to 5 different batteries of questions. So one battery from one particular client and then another battery from another client. And we use it in this case for an ARP commissioned research that NORC was happy to take on. Our measures you can see in the middle column there are the ones that you might expect. We really focused on loneliness and anxiety measures. We did have a question in there about mental health care use. To be clear, these are all self-reported measures. There's no attempt to look at administrative records or provider records. This is simply a self-report survey. And we looked at diet and a few other measures. In terms of the details of the survey itself, the Foresight 50+ Omnibus typically has about 1,000 interviews in it, which we did for this. And we also conducted the survey both online and phone back in April. And as you can see, it's a very short turnaround. It's only about a 4-day field period, because our goal is to be able to give our clients data back and findings within 2 weeks. So the whole project takes 2 weeks or less. All right, moving on to the next slide. This is the findings slide. I do encourage everyone to just simply, if you Google the ARP COVID mental health study, you'll see the more extensive findings. But essentially, we found out that we were all justified in our worry about the mental health of persons age 50 and older as a result of COVID. And particularly if you look at the mental health measures, 7 out of 10 self-reported an increase in sadness or depression that they attributed to the pandemic. Similar measures in terms of worrying about the future. So the outlook questions consistently showed increases in worry and loneliness. The socializing stat there, you see of 62% self-reported socializing less. That's not surprising given the isolation, but it's more confirmatory and corroborating, I think, what a lot of us feel is the case for all Americans, but particularly people age 50 and older that were more susceptible and persistent, remaining more susceptible to this illness. Depending upon your outlook on life, the 27% number on seeking spirituality may be refreshing or not. It may be an indication of the worry level, or it could mean that people are, literally trying and are inspired to have more depth in their way of thinking about life. So those were a few of the highlights. And if you go to the next slide, just as a reminder, in terms of the Foresight 50+ Omnibus, we encourage its use for multiple purposes. It doesn't always have to be, relatively high-minded academic research or public policy driven. We do encourage consumer market research studies on it, because our feeling is that well-done consumer market research studies of this population can help with product development and improvement of services that benefit persons age 50 and older. Okay, so we'll move on to the second case study, and I'll be happy to take any questions that you have later about the first case study. So this is the RANDS project that we conducted for the CDC and NCHS. Next slide, please. And why did NCHS come to NORC for this work? Essentially, we had a contract in place already with NORC's AmeriSpeak unit conducting surveys for the RANDS initiative. And in this case, with the onset of COVID, there was interest in conducting a large sample size survey in a very timely way to measure a few issues. And I list the issues here, and I'm going to come back to them later with some selected findings. So we were happy to take on the work. The real challenge to this project is we needed relatively large sample sizes in order to pull off the statistical precision needs. And if you move to the next slide, you'll start seeing how we pulled that off. Essentially, what we did was use our AmeriSpeak panel sample, which is probability-based, nationally representative, has the highest response rate at the panel recruitment stage of commercially available panels in the US. And that is attributable, of course, to our face-to-face refusal conversion work we do with NORC field interviewers. We combine the AmeriSpeak sample with the non-probability opt-in samples, which are commercially available. And I think many of you probably use these non-probability samples. Our point of distinction here is that we have developed a calibration weighting routine, which we call True North. And that True North weighting routine allows us to make best efforts to reduce the error that's being introduced by using the non-probability opt-in samples. Many of you probably know that the non-probability samples tend to have predictable error in the self-report of behavior, of knowledge and awareness. So a typical knowledge, attitudes, and behavior survey on a non-probability panel will tend to give you higher measures than on a properly selected probability panel. So we developed this calibration weighting routine and applied it for this project. And by moving to the next slide, I can show you a little bit more how that worked. If you look at the left column there, essentially we used the Amerispeak part of the sample for the longitudinal two-wave survey. We felt it was very important to have a relatively large sample size at baseline. And as you can see, we had almost 7,000 interviews with general population adults at baseline on Amerispeak. And then about 6 to 8 weeks later, we did a recontact, re-interview study with that sample and had almost 6,000 successful completions among the baseline. So we have a relatively large two-wave survey sample size for analysis there on COVID-related behaviors that NCHS was very interested in. But we wanted to be able to have the statistical precision to really drill into some very specific subpopulations. So for that purpose, for the baseline survey and the first follow-up, we did supplement the Amerispeak sample with approximately 6,000 interviews each time from the non-probability surveys. So for the cross-sectional part of the analyses, we did have available to us almost 12,000 interviews for the June and July baseline. And then for that first follow-up period, you see in August 2020, we did have about another 5,500 interviews for the non-probability. So that gave us a lot of statistical precision. And for the cross-sectional surveys, we, of course, used our calibration weighting routine that I briefly mentioned. Okay, next slide. So I have 3 finding slides here. These are slides that are taken straight from the NCHS RANDS data tool. So they have on the website a pivot table that you can use. So you can select whatever measures you're interested in and cross them with various demographics and socioeconomic characteristics, et cetera. This first one I thought was interesting because of the explicit measurement about the previous week of individuals being unable to work because either they themselves were ill from COVID or a family member was ill. And the numbers are small. You can see the 2% number for the age 18 to 44 group, but just recall that that's on a per week basis. It's looking at the previous week only. And the call out for me is that by having the relatively large sample sizes, we're able to reduce our standard errors here quite a bit and have some confidence that we were seeing some real differences here across the subgroups. Okay, next slide, please. And then the next question is about telemedicine. I think what's interesting for me about this is still the relatively low levels of self-reported access to telemedicine. You can see that the number is hovering between 30 and some 45% of individuals reporting that they had access to a provider that is engaged with telemedicine. I think the other finding there is just looking at the 65 and older group being more aware, maybe they're more motivated to seek out telemedicine and hence more aware that their provider has this capability. And then finally, on the last slide, I wanted to just share with you the information about individuals that were unable to receive a regular checkup in the last 2 months. So these are individuals that sought a regular checkup, but were unable to do so. And again, because of the relatively large sample sizes here, we're able to detect some trends here. Very early in the pandemic, if you look at the black bar on the left side there, you'll see that the lack of access percentage is slightly higher, and there's a directional trend in a positive direction, actually. So just actually access is slightly improving as time moves on. So that was an encouraging trend, but I think it does show that early in the pandemic that perhaps our providers were overwhelmed and that there was a spike in terms of lack of access to regular care. So that concludes my findings and my presentation as a whole. and look forward to taking any questions that might come up. Thank you.
Great. Thank you, Mike, David, and Jennifer for those very informative presentations. We have a few minutes now, and so I want to field some of the questions you all have submitted during the session. So the first question is for Mike Dennis. So you would expect, and your studies somewhat reflect, that COVID has put a lot of mental and physical stress on older Americans. Is there any number in your findings that struck you as being exceptionally high, or one area that is of particular concern?
I thought the Foresight 50+ project measuring the mental health issues, particularly around isolation and loneliness, I thought those were striking. I thought there's absolutely, usually when you do surveys about public health issues, if you see a behavior such as smoking in the 10 to 15%, we worry about numbers that are relatively small when it comes to risk behaviors. To see numbers like this in the 70 to 80% range, as someone who's not a specialist in that area, it still struck me from a survey perspective that these are robust findings.
Okay, thank you. The second question is for Jennifer Hamilton. How does the rate of low income versus high income AP students who took AP exams compare to previous years? Were their reasons the same as those you heard regarding remote learning, such as tech and Wi-Fi challenges?
That is a very good question. So we didn't directly ask the students in the survey why they didn't take the AP test, but we know that a lot of effort went into encouraging them to take it. So we know, we talked to the College Board and asked them what they were doing, and they were doing a lot. Like I think I mentioned, they were handing out kind of mobile Wi-Fi devices and laptops, and they were calling everybody and waiving fees and doing all kinds of things. But still, that difference between the higher income and the lower income kids was very telling. And I can hypothesize that even with all of the outreach from the College Board, they maybe just didn't feel ready. They didn't feel like they had it in them to take the test. I mean, kids are going through a lot of trauma in addition to, not being in school. So it could be, a number of different reasons kind of behind the not taking the exam, once they had already been in the class and had it registered and everything. And one thing that we don't know, and I know this question was in the Q&A, is that we don't know what these numbers were prior to COVID. So we know from our survey in 2020, the number of students who enrolled in the class and didn't take it. But we don't know what that was prior to COVID. So it's hard to make kind of those kinds of inferences. We asked the College Board and they know who took the test, but they don't know who enrolled. And so getting, both pieces of that information is really hard, and it's just not really reported anywhere. So in the future, post-COVID, if we're ever post-COVID, we'd really like to collect that information, and because it's a very, I think, important piece.
Great, thank you. And thank you for addressing the other question that was in the Q&A as well. With that, I have a question for David Cotton that someone submitted. The question is, I assume you've had a lot of people who've picked up the phone and were skeptical. Was there anything critical in the script that made you think people trusted you more and gave you the information that you needed?
That's a great question. And I'm not sure if it was anything in the script per se, but I'd say there are a couple factors that were in our favor with this. The first is that the contact tracers being from the local area and being so passionate and committed to their work really, I think, made connections with the callers. And so I think that's the foundational aspect of what made this successful. the early acknowledgement that this was a health department supported, driven, that we were doing it on behalf of the health department. I think for a lot of folks who were not overly skeptical about the process or COVID issues in general, that was enough to help legitimize that activity for them. And the training that the contact tracers received included, I guess, the equivalent in the survey world of non-response conversion, but learned how to work with the respondent to gently encourage them to participate in those ways. And there were a lot of people who didn't pick up the phone. There were a lot of people who required some level of working with them to get them to respond. But ultimately, I think we had a very sizable response.
Great, thank you. And I have another question for you, David. The texting before calling would seem to be super smart. How much of a bump in response rate did that cause? Should all survey organizations be texting before calling?
Easier to answer the first part than the last. So the texting created a big bump, required us to rapidly increase the number of inbound callers that we had on staff, because we were getting the message, the text message gave them a number to call. So in fact, it met its primary purpose, was getting people to proactively reach out to us, not just be getting ready for a call. In fact, it was much more than we expected. So not only did we have to increase the number of inbound callers, we had to modulate the number of text messages that were going out in any period so that we could in fact have enough response capacity to not create long wait times for the respondents. So I would say it was very successful. Should it be done in all survey research? I think it clearly has applications. To be honest, I haven't really thought through the methodological aspects of whether there's anything that it may negatively imply for representativeness or things of that nature. But I think just in terms of people feeling that the call is legitimate, as I know I do, and probably a lot of people on this webinar do, if you see a number you don't know, you reject it. And we found that even if we had a caller ID or a branded caller ID, less than 10% of cell phone plan holders, in fact, pay for or get that service through their provider. So some other way to legitimize that single number, I think, is a very useful tool.
Great, thank you. And then the next question is for Mike Dennis. Can you speak to the success or lack thereof for recruitment and retention of African American and other racial ethnic minority populations in your studies? What lessons should we embrace moving forward to improve diversity of human subjects research?
Yeah, it's an interesting question. It's an issue that the entire industry, to some extent, is attempting to address. I would point out that some of the solution, at least, is anticipating higher attrition rates from various segments that join AmeriSpeak or other panels, and oversample those groups at the front end of building the panel. And that's essentially what we've done at NORC with the AmeriSpeak panel. Is statistically over time, we've become quite precise in our forecasts of what the retention/attrition rates are going to be by the various demographic segments that make up our society. So we can use big data/auxiliary data on the front end of our sampling for building our panel assets to oversample these different groups or undersample them in proportion to their propensity to join the panel and propensity to stay on the panel, in other words, be retained. So some of the solution, at least, is on the front end. And as a result, if you look at AmeriSpeak as a panel, we do have a overrepresentation of African Americans on AmeriSpeak because of the anticipated perhaps lower retention rates over time. That's just one example. The more chronic issue involves the so-called lesser acculturated Hispanic households that are both harder to identify and recruit initially and retain. So that's its own research agenda.
Great, thank you, Mike. And the next question is for Jennifer. The AP tests were drastically rewritten in 2020 in response to the pandemic. For example, the AP statistics exam was shorter, administered online, and covered less material, and was a different format than previous years. I wonder whether the research team has considered this confounding factor when considering how this may have impacted student decisions to take the exam.
Right. So, when we were looking at these data, we called up the College Board to ask them exactly, what was happening with the AP's exams. And, they said as much. The exams were changed. They tried to make it much, much easier for folks to take the exam. As I said before, they were sending out all of these devices and waiving fees and doing really everything they could. So the fact that there was still such a high number of low-income kids not taking the exam, despite all of these efforts, is, I think, the real take home. And unfortunately, as I said before, we don't really have a basis of comparison because we don't know what those rates were prior to COVID. All we know are the spring 2020 rates based on the AmeriSpeak teen panel. So it's really just a descriptive snapshot in time. And that's kind of the only way we can present these data.
Great, thank you. And the next question for David is, were you able to, or did you isolate by race ethnicity? If so, what were the challenges that the Hispanic community faced? And I wonder if this question might actually be for Mike Dennis, because there's also a related question about how did they deal with loneliness and was their experience different than others? So excuse me, I guess this will be for Mike in terms of Hispanic community findings.
Susan, could you help me with what the question is exactly?
Sure. So the question is, were you able to, or did you isolate by race ethnicity? And if so, what were the challenges that the Hispanic community faced in the findings that you presented?
Yeah, our sample sizes are relatively small for the omnibus. It was just over 1,000 interviews. I don't think, but I have to look at it to be sure that whether we actually analyze that data by those subgroups. That would be, in my view, a more it's obviously a great question, but to have sample size of only 1,000, we would be on the cusp of not really having enough quantitative information to assess that within our omnibus. But I have to look at see if we actually did analyze that.
All right, thank you. And I guess I will. I'll note that I'll just sort of double, check in with you, David Cotton, if there were any concerns or considerations in the contact tracing that were specific to the Hispanic community.
Sure. So relative to their issues with isolation or feelings of loneliness, that kind of thing, we did not analyze that. In this case, NORC was not asked to be the researchers to analyze the data. We were really on the data collection and client-facing side of things. So the health departments have those data and are looking at them by various racial and ethnic groups and other ways of looking at the data. What I can say is that we definitely have multilingual contact tracers, and particularly Spanish speakers. So for anyone in the Hispanic community that had Spanish as their preferred language, they were able to do the contact tracing interview in Spanish. And I think that thinking about what the impact is of needing to isolate, the feelings of loneliness, the implications for economic impact of people needing to isolate, those are all really important questions that need to be answered and thought about both for COVID and subsequent situations like this.
Great, thank you. And for Jennifer, can you tell us more about high dose tutoring? How does that work?
Boy, can I tell you about high dose tutoring. So in looking at ways to kind of accelerate learning post-COVID, high dose tutoring comes up a lot because there is such a robust research base for it. There's been lots of studies, and I think most recently out of the University of Chicago Education Lab, they released one in March that showed that high dose tutoring tripled the amount of math high school students learned each year. So that's, I mean, in education, that's just crazy, right? That's a lot of gain, and we don't usually have that kind of gain. So people are pretty excited about high dose tutoring, but the problem is how do you do it at scale, right? It's kind of expensive. It's kind of a one-on-one or two-on-one for 45 minutes, like every day. So it's very hard to do it at scale. Now the governor of Tennessee has created the Tennessee Training Tutoring Corps. So he's doing it like statewide using using college students. And he's funding it, I think, personally. I think I read that to try, you know, as an effort to kind of pick up the pace and accelerate the learning. And in terms of going to scale, we just did a study of high dose tutoring for the College Board in New York City and Chicago, looking at how it could be done remotely. So having remote tutors tutor 3 kids at a time in high school in math. And, you know, there were some challenges, but it seemed to be an approach that could work. And so I'm kind of optimistic about it. So I think that I'm gonna stop there, or I'll just keep going and we'll never stop.
Great, thank you. And we have time for one more question. This will be the last question. And I will direct this to David. I think this question's on many people's minds, and it might be a hard one to answer, but it's about the response rate and contact tracing. Was it better than you expected going into the project?
I think I had limited expectations going in, to be honest, just because it had never been done at this scale. And so we were originally had goals for it to be higher, but I think we found that our response rate is pretty consistent with what we've been seeing across the country and other states and cities. So I think in that respect, it's been successful. I also think that when you think about the public health impact, I just heard a figure on the radio this morning that the average hospitalization due to COVID costs $73,000. So if 100,000 cases were averted by people not spreading it and spreading it more and through their network, 10,000 cases would be $1 billion of savings. So whether the response rate could have been higher, I think the impact of the response we got is considerable.
Great. Well, on that point, we will conclude, and I will say thank you all so much for joining us. On the screen, you'll see contact information for everyone who presented today. And please do not hesitate to reach out. And we'll also be sharing today's slides in the email after this webinar. So again, thank you so much to our panelists, and thank you for joining. Goodbye.